Yay.
Yeah. I was sacrificed. That's not.
Oh, yeah, I guess you gotta share it and pick his.
Okay.
Close all these.
No.
Okay, so let's come find your PowerPoint.
Yeah.
So you should be on here.
No.
No. No,
The first one you have there.
this one,
Sure this one.
this one.
I didn't even hit on slideshow.
Yeah, I
Already
did it.
closed all those other ones. That's other people have them open for a reason.
I have mine open.
Okay, there we go.
I don't
And
guess.
then do slideshow. Okay.
I don't mess you up.
What did we have to do with Zoom?
Well, no, the Zoom's already got recording.
Yeah, that's right.
That's what we're good, okay. And just do
It's like
slideshow,
having from the beginning.
and then you should be.
Yes.
Is sharing.
Again? Is it Sharon?
Yeah.
Yeah, I haven't.
I was planning on using that. Okay, that's not. All right. Well, I'm James Young, senior here at Piedmont University. I think I know most of y'all, except for a couple of you. Today, we're going to be looking at relationship between ketamine and its relationship with depression. Ketamine is a very powerful anesthetic. It's used in surgery for people, knocks people out. It's also heavily used in the animal, veterinarians and stuff. Works on very large animals, horses. So it's a very, very powerful anesthetic. There's also been a lot of psychopharmacology type aspect of it in the past 10 to 15 years, and that's been gaining a lot of more traction in the past, especially in the past 10 years. There's been ketamine infusion clinics that have been popping up here, even here in town. There's at least 1 or 2 clinics here in town that you can go get ketamine infusions. So today we're looking at what is the impact of ketamine therapy in adult populations with treatment-resistant depression. So a little background information, treatment-resistant depression, or TRD as it's called, is a major depressive disorder where traditional depression therapies have been failing. Patients can be clinically labeled with TRD when 2 or more antidepressant therapies have failed. So that's going to be your SSRIs, your SNRIs, so maybe some of your atypical antipsychotics, where those have been not working as effectively as they should be. About 6 million people in the United States are resistant to conventional pharmacologic, somatic, and physiological therapies. You got psychotherapy, you've got things like ECT, the brain stimulation things, where those things have been not working as effectively. What in the world?
It was doing that earlier, changing without people trusting.
I'm sorry.
It's not your fault, it's the technology.
It throwing me off. Where was I? Where things were like the ECT therapy have been not working as well. There's lots of different things, and some people just don't respond to as many of these therapies as they should be. The U.S. Food and Drug Administration has now approved the use of ketamine and esketamine for the use of treatment-resistant depression. Now, you'll see it ketamine and esketamine in these slides. Esketamine it's a derivative of ketamine. It's also a little bit stronger. Both of these drugs can be administered through intravenously, intramuscular. They can be done sublingual as well as intranasally. The primary ketamines, typically you'll see it done with the research and with IV intravenous administration, and the esketamine has been approved by the FDA. There's an intranasal spray that's been approved for that, so it's just like a little spray. Okay, going into some supporting literature. This study right here was ketamine and treatment-resistant depression. It was a very, It was a very large cross-examination of 10 different studies that were done and brought together and then analyzed together. So it had a very large population and study size that it was done. So the reviews analyzed reported improvements of 50% and greater decreases in reported symptoms of major depression across the different reviews. Most of the research observed reported significant decreases in reported depressive symptoms at 24 hours of a single infusion therapy. And you'll see this continued on. It has a very quick rate of effectiveness. It has rapid and robust effects that were noted within 40 minutes to 4 hours, currently showing fast improvements in symptoms. Results gathered in the study show infusions provide rapid onset with minimal side effects, and they tended to be well tolerated by individuals. This was a paper called The Use of Esketamine in Comorbid Treatment-Resistant Depression of Obsessive Compulsive Disorder Following Extensive Pharmacogenic Testing, a case report. This was a study that was done, this was a single individual, so it had a lot of very detailed analysis of a single person. After the induction of the esketamine, the patient showed a rapid resolution of depressive symptoms and increased drops during maintenance phases. The Montgomery-Asberg Depression Rating Scale showed a drop of around, is actually closer to more like 70%, honestly, by the 10th administration of esketamine. Now, the Montgomery-Asberg Depression Rating Scale is it's a tool that psychologists or psychiatrists would use. It's 10 questions. It gives a rating, lower number being less depressive symptoms, a higher number would be more severe depressive symptoms. And that scale is going to be right here on this red one right here. And you can see the bottom numbers of the amount of administrations of the esketamine. And starting with the first administration, it is done weekly. You can see the drop, very dramatic drop, and it continued to drop. And at the 8th administration, it moved to every other week. And you can see it still maintained a really good rate in the maintenance phases. And then it moved out to a monthly. And it was still holding pretty good into monthly. This was an article called Intranasal Ketamine for Depression in Adults, a systematic review and meta-analysis of randomized, double-blind, and placebo-controlled trials. This was 5 different random controlled trials. It had a very large population of people that were subjects, a little over 840 people. The responses in the study kept showing over more than 50% of decrease in going back to that Montgomery-Asberg rating scale again. And remission was defined in the study as less than or equal to 9. Drops in the scores were recorded as averages of 6.16 in 2 to 4 hours, 9.96 at 24 hours, and 6.78 at 28 days. So you can see the 6.16 here is below the remission level. And there was a little slight jump at 24 hours, but still very good results. But the most important thing was that 24 at almost a month out, it was still holding at 6.78, which is showing very good results for long-term control. And some common side effects observed in the study were nausea, vertigo, dysgeusia. That is, dysgeusia is altered taste, disassociation and dizziness. Symptoms also resolved within a few hours of administration. The results of the study show that once again, it was a fast onset. The antidepressant results were in repeated intranasal ketamine administration combined with mild and transient effects were noted. Okay. This was a head-to-head trial of analysis called the Evolution of Trajectory of Depression Severity and Ketamine and Esketamine Treatment in Clinical Settings. So this one was a little bit unique. It was not just looking at the results of how well it worked. It was also comparing the ketamine with the esketamine. The ketamine was an IV administration on this study. The esketamine was intranasal, and it was also used in the Montgomery-Asberg scale and also a quick inventory of depressive symptomology self-report. It's just another type of similar questionnaire type scale that they psychiatrists and stuff use for depression rating. And between the patients, it was showing averages of 1.59, 2.49, and 1.64 differences. And that's the differences between the ketamine and the esketamine, with the favorability leaning towards the ketamine. Both treatments showed a reduction in symptoms, with intravenous ketamine being the favorite of the two. It's possible that the intravenous could work a little bit better versus intranasally. Could be lots of different factors there, but that's probably some additional research that needs to be done on the two. This was a large retrospective analysis. This was an interesting study. This one was nationwide, over 9,000 participants in this study. So it wasn't just limited to a particular clinic or a geographical region. It was limited to a large population across the country. They sent out a patient health questionnaire. So this would have been self-reported. It's 9 questions. And basically the results that were coming back from this, once again, was showing a 53.6% patient showed a response of greater than or equal to 50% reduction in their PHQ-9 scores. Also, the 14 to 31 days here still showing excellent long-term control. 28.9% showed a remission rate of scores of less than 5. Interesting. There was a small subset on this study that showed an 8.4% increase in depressive effects. How that would pertain to traditional SSRIs, SNRIs, it's probably pretty good results. And overall analysis and tests in the study show an 80% probability of a sustained therapeutic response and a 60% probability of a therapeutic response beyond 8 weeks. For the IV, this one was IV ketamine therapy. This was an open label study called the Efficacy of Ketamine Therapy and Treatment of Depression. It followed 20 patients. This one used a Hamilton rating scale. It's just similar to the other ones, just a questionnaire. The lower the number, the less depressive effects the person has, the higher, the more depressive effects there were. The base mean of the participants was 23.40. That range is kind of on the high end it's on the high moderate end, or kind of the low severity, kind of in that teetering between moderate and severe range for these depressive effects for the 20 patients. After 1 hour, it dropped to 21.20, slight decrease. After 2 weeks, the rating was 10.25, more than 50%. And at 1 month after the last dose, the rating was still holding on at 10.45. So once again, showing very long-term therapeutic results on that. Only 9 patients of the 20 experienced mild transient effects, and the effects dissipated within an hour. So it shows that it's pretty well tolerated, once again, for adverse effects. And the final thoughts of the study show significant improvements in depression, anxiety, and the severity of the illness. After 2 weeks interval and 1 month out intervals from the last dose of ketamine therapy, they still show significant improvement. Okay. So kind of synthesizing some of the literature and some concluding thoughts on it. Traditional antidepressant treatments taking weeks to have effects, in addition to treatment-resistant depression patients having limited option. There's a therapeutic gap that warrants other available options. There's a lot of possibilities there with this. What's to say you couldn't, somebody that's having some severe emotional responses going on in their life, these antidepressants can take weeks to have effect. What's to say that this person couldn't have some ketamine therapy for very quick upfront results, therapeutic responses, and used in conjunction with other traditional treatments while those kicked in? So there's a lot of really good applications that this could be used towards. The effects of ketamine therapy were robust, and they were quick in reducing symptoms of major depression, and effects of greater than 50% were common in pretty much every study that I ran across. several randomized trials, patients saw a 50 to 70% positive therapeutic response to ketamine infusions in the first 3 days of a single infusion. Side effects were nausea, vertigo, dysgeusia, disassociation, and dizziness were mild and moderate in nature, and they typically resolved the same day as the treatments. And final conclusions of ketamine for treatment-resistant depression seem to be very bright and robust. There's still a lot of long-term research that needs to be done on a lot of this stuff. Most of it was all in the past 10 years. So it's kind of modern, and it's still kind of growing. Ketamine clinics have still been continuing to pop up across the country. They need a lot more studies focused on the varying dosages, the frequencies, how they interact with the other medications, and trying to optimize, balancing the efficacy of the drug with the side effects. And it seems to be a very good direction that they're heading in. I have a personal friend that's been having ketamine infusions here in town. I thought about using her in the presentation today, but she's been very, very sick. She's been having seizures daily, can't drive. I asked her some personal questions and let her look through my research, and it kind of it mirrored pretty much what her experience was. She saw really very, very quick results day one of her infusions. She had IV ketamine infusions on which she was having done here in town, and she said she was still feeling good a month out, compared to where she previously was. So it seems to be a really good direction that we're heading in with some of this research. It's probably not going to be turned into something where it's like a first line type drug, or it's not something somebody's going to go to initially. It's going to be used in conjunction with other therapies, psychopharmacology type things, and traditional antidepressants and therapies and such like that. But it seems to be a really good direction we're heading on this. So. And that is the end of the selection. So.
All our questions at this time. Thank you so very much. Then. Oh. I told you I was Well, hold on, let me enable. Maybe I need to do that. So cancel, whatever that is. How you do it on here? Hold on. I don't sew it up. I know. How you cancel on this side then? Okay. And my thing ain't even moving. Oh. How's that? Yeah. Let me show. All right, go. All right. All right, good afternoon. I am Tia, and I'm doing my PICO presentation on does Tamiflu increase neuropsychiatric events after taking it. So this presentation is going to highlight you as a consumer. It's going to highlight people as nurses, as in healthcare, about being your awareness of taking medications. You need to make sure that you're being an advocate for your own healthcare and seeing if the medication you're taking, if it outweighs if the medication that you're being prescribed if it outweighs the good. So as you can see here on the screen there, you don't have to be a professional to be an expert on medication that you're consuming. So the question I pose to you guys today is, doctors don't know the drugs that they're taking, that they're prescribing, or do they? So let's explore that. So today's presentation, we're going to go a couple topics here with your background, purpose, and goal of taking Tamiflu, some adverse and adverse effects of Tamiflu, the case studies that I looked at, some literature review, and then results. And finally, how does this relate to consumers and how's it important to you guys? Okay. So we all know someone that had flu before, flu symptoms, body aches, chills, fever. So we know that flu is a virus. It's a severe respiratory infection that typically occurs between what they call the flu season, which is December through March of each year. Now, Tamiflu was the go-to drug. Tamiflu was invented in 1995, and it treats both flu A and flu B, as well as the swine flu. It is prescribed for people who are 2 weeks of age and older. And typically, how the dosage works is if you're going to do regular treatment, they'll give you one pill. You take that for 5 days. Or if they say, hey, my brother got it and they want to treat them prophylactically, they give them one pill and it takes it for 10 days. So, or longer, according to what the website says. So in order for Tamiflu to be effective, they want you to take it within 48 days of having the onset flu-like symptoms, with the purpose of trying to cure the flu at its source. And the goal is to prevent it from spreading. So as you can see on the screen here, my question is, when you get your medications, how many people read the back of the labels and see what does it do? Okay, good. So most people don't read it. Most people just say, hey, or some people might say, hey, how does this medication affect my side effects? Or how does medication affect other medications I'm taking? Or I'm just gonna take the medication because my doctor, he's a doctor, he went to school for it. I'm gonna take it. Oh, Jesus. Okay. Okay. Yeah, he having fun with it. So anyway, pretty much if you can stream with the show, it was the side effects of Tamiflu. Tamiflu has fatigue, some vomiting, some nosebleed, headaches, and nausea, but they don't talk about what the adverse effects. So some of your adverse effects is some confusion, convulsions, some kind of visual hallucinations, as well as people having suicidal harm and ideations, which means, they're actually doing self-harm to themselves. So ultimately, who's at risk when you're taking Tamiflu? Is anyone, pretty much. It affects anyone. The household researchers have found that 92% of neuropsychiatric events happen after taking Tamiflu. This happened, we've seen more in males versus females. And then also more prevalently in pediatric versus adults. And more research is being presented on that because they kind of think maybe that is related to them being a teenager and going through all the hormonal changes as well. So in addition to all that, it also can be linked to taking Tamiflu for a longer period of time. So remember, if you're taking it prophylactically and you're taking it for 10 days, you can still see the same amount if you're seeing it within a short 5-day cycle there. So the BPCA, which is the Best Pharmaceutical Practice for Children Act, they identified that Tamiflu within children aged 16 and younger. They reported unusual neurologic or psychiatric events that are happening to those adverse effects that was supposed to be on your screen here, but it's not. But in addition to, it also has what they call encephalitis, which is the swelling of the brain there due to inflammation and infection of it. That can lead to headache, stiff neck, sensitivity to light, and as well as mental confusion and seizures as well. I don't know if it's gonna let me get the rest of it.
Try to hit play slideshow and see if they'll pull up.
It's coming up.
Here comes the thing.
Yeah.
You're doing great.
Okay, I'm gonna roll a bit, Mm-hmm.
I just hit escape, so I don't know why. Hope it picked back up what it was.
Okay.
Did it? Or
Yeah. All right. So I did two reviews on the case studies. There were single case studies, and the first one was a 22-year-old male who went to a psychiatric facility. He was complaining of some mood changes, some suicidal ideation, and ultimately they referenced the medication was the cause of him having those symptoms. He had no prior history of any kind of mental health issues, no psychiatric history, no family history of it. And he was given the antipsychotic medication, and ultimately his symptoms dissipated after taking that. This case study, two single case study as well, 15-year-old female. She was a Japanese girl. She had symptoms of delirium, visual hallucination, and she suffered from long-term memory deficit of taking the standard doses of Tamiflu. Same thing with her. She had no history of it. And she had no previous, when she had flu the previous time, she had no kind of infection from that and no kind of reaction. Gave her antipsychotic medication, her symptoms went away. I had a video that was supposed to be just going to show, but I'm just tell you about it. It was a video showing a parent had gave their child flu medication, Tamiflu, because they had it. He never had any symptoms before, and he ended up committing suicide. And they was like, down on themselves and saying, hey, if I would have known about this beforehand, I would have gave this to my child. Then a doctor came on and he spoke about the effects of Tamiflu and why he doesn't prescribe it. And if it is been prescribed, you only getting a 12-hour relief of your symptoms. So it's so that would have been interesting for you guys to see that on that one. And then the next slide there was my research articles. My first article was about a 60-patient study. It was about the Tamiflu showed more psychiatric symptoms in patients. The symptoms ranges from mild to severe. This made the FDA put a warning label back on in September of 2009 as far as the labeling of how we should be looking at medication wise. And it also drew an urgent need for medical professionals to go over their health history with their patients prior to them giving any Tamiflu, because if you have a history of it, it's going to increase. If you don't, or you have a family history of it, you have a chance of it exacerbating. So Article 2 was a 15-year-old male. He had sudden and delayed onset after taking Tamiflu. So it's not showing that he is not just, some people have it in the beginning, some people have it throughout. So it's not a particular time when they're shown that it's had it, but he had it throughout his 10-day symptoms. So he was still on the medication for 10 days. I don't know what the reason for that part, but he was still on it, and it showed that he had his treatment affected his central nervous system. Article 3 showed that it was a greater incident regarding the participant's age or gender. So it didn't matter if it was a boy or girl, he was pediatric or 28 years old. And this study was interesting because it showed that the actual medication Tamiflu crossed your blood-brain barrier. If you know what the blood-brain barrier is a like tidal cells that is supposed to keep harmful substances from going to the brain. And so it showed that Tamiflu is actually crossing the blood-brain barrier. Article 4 was about a 32 clinical trial. This is where they treated people prophylactically, and it showed the same thing. More people was causing more harm with increased dosage and duration of taking the medications. So you got to be your own advocate for yourself and see, hey, do I want to treat myself and my kids, even though I don't have symptoms? Is that good going way off the bat? So the last article was a two study one. It was 2 Japanese girls. They were high school students, and they actually died in February of 2007 when they jumped off a building after taking the Tamiflu. So this prompted the Ministry of Health and Labor and Welfare the following month to go ahead and put a safety information and prohibit the administration of Tamiflu to ages between ages of 10 and 19 years of age. So they seen the same thing. They was taking a medication for a long term, and that's what's the cause of that. So I do have this picture here. You can see most of my research was more prevalent in Japan, because Japan is the most consumers of the Tamiflu. So you can see in comparison to the United States, it's a smaller scale, but they are the ones who are consuming it more. So that's where most of my research studies was coming from. And on November the 18th of 2005, this is when the Pediatric Advisory Committee met to discuss the warning labels of Tamiflu. This is after 600 cases of psychiatric problems were reported in Tamiflu. Like I said, with 75% of those studies coming from Japan. Lastly, I'm just going to reiterate, does the doctors know what they're prescribing, or do they? You have to be your advocacy, to your own research and see if that medication is going to be good for yourself, it's going to be good for your family. And I'm advising you to challenge yourself to pay attention, ask the necessary questions in your doctor's office. Don't just Don't just say, hey, he give it to me, this is what it is. So I need to make sure that benefits outweigh the risk. So at the end, be your own advocacy, say this is my health, my voice, my choice. That's it. I don't know how to do that, but. Yeah. Power statement in there. Okay.
I don't know what's wrong.
I don't know. Yeah.
It's been doing that, it's been doing it all day.
Okay. I broke the whole.
Need you to cooperate. Cooperate.
Did I not do it right? I thought I did. I'll let you do it. There it is.
About to get weird.
If it goes out, hit escape and see if that's what he said he did last time.
All right,
And we'll see.
we're gonna wing it. That's all we can do. That's all we can do. Oh. Hey, I'm Ryan. I know most everybody in here. So that's me. Let's see here. Yeah. Yeah. Okay. So my presentation is going to be on the impact of hysterectomies on mental health. I think the full PICO question was the impact of hysterectomies on women of childbearing age. But we're just going to generalize it for the sake of this presentation. So little history. Hysterectomies, just in case nobody knows. Hysterectomy there's different types, but for the purpose of this presentation, we're going to focus on total hysterectomies. So total hysterectomies are the removal of the uterus and the cervix and possibly the fallopian tubes and ovaries. With that, prevalence of this is actually larger than I would expected. It's over 500,000 in the US every year for the CDC. And that's a lot. That's a lot of hysterectomies. So, and this is second in women to the C-section. So that's second to the C-section. And in total major surgical, it is second to the appendectomy. Didn't know that either. So with that being said, most of my research that I'm going to go over is not within the US. I got a lot of Western type research, a lot of Turkey, Pakistan, Sri Lanka. It was Iran. It's kind of weird that the US didn't really have any documented research. Found that kind of interesting. Pretty much in the Western world, 6 in every 100 women ages 30 to 49 have had a hysterectomy, and 11 in 100 women ages 45 to 49 have had a hysterectomy. So that's 10 to 20% of all women within that age group. That's a lot. So by the age of 60, 1/3 of all women would have had a hysterectomy. The main reason reported are basically heavy menstrual bleeding, fibroids or cysts, uterine disorders of any type, or disruption, uterine prolapse, and any other kind of life-threatening uterine issues. And they come with risks. Obviously, total hysterectomies, if you take everything out, you're going to go early menopause, you're going to experience those kind of things because that's your main point of estrogen. Excessive bleeding to the point of where you may need a blood transfusion that comes with surgery, injury to other organs within that area, the bladder, the intestines, scar tissue formation, which can be very painful in the abdominal cavity, and blood clots come with any surgeries, infections, typical stuff. So we'll bounce into some supporting evidence. Got a couple articles. I'm going to use this since this seems to be a little bit unpredictable. So my first article, it was a group of about 41 patients out of Turkey. 17 did not receive hysterectomies, 24 did. This was a short study. It was about a month long in 2015. they were invited to the clinic to go over everything based on their previous hospital stay. So the purpose of this article was to investigate postpartum depression after emergency peripartum hysterectomies. And what they discovered is there was an increase in ICU and infant death rates due to complications in the hysterectomy group, which is the 24 women. And you had increased postpartum depression due to that. Obviously, if you lose a child, it's very depressing. You know, lose an organ, very depressing. So they went about this, they used the Edinburgh postnatal depression scale to evaluate these women for the postpartum depression. And they discovered that organ loss increased depression 114-fold. So if you lose an organ, your uterus is pretty important to women, especially if they were in the reproductive age range and they couldn't have kids anymore. So that's kind of a hard hit. And they also discovered the lack of menses accelerated aging process. That's how they felt. So it was marketability that really sold this article. It was anonymous and optional. However, underlying reasons for depression were a major limit to the study because they didn't know if they had any of that or not. Okay. So, article number 2. We're going into just a multiple. So this wasn't really like a study. This was more of like a cross-examination of a lot of literature. It's a very vast date range, as you can see. They explored a lot of medical journals, and I kept this one. I kind of didn't want to keep this one, but I did keep this one because it had such a large date range and a lot of information. Some strengths of the study had a lot of information across a lot of, what am I trying to say? Date ranges. But it had a lot of different perspectives. So they discovered in this one that the strengths of the study limits the. Hold on 1 second. I think I lost my place. Oh. So postoperatively, when they were properly educated prior to surgery, they had solid support system, and the postpartum phase, they did a lot better. So they were looking at depression rates after this procedure, and they said that people with support rates and they had education on what would happen after did remarkably well in this study. So there's that. Okay. Article number 3. All right. So this article was out of Sri Lanka, and this is about a year-long study, so that's a really good date range. The study included women who underwent a peripartum hysterectomy, both elective and emergent. The study explored peripartum hysterectomies in tertiary care units. So that's like a very long-term physical unit. So they stayed there for almost a year, and they documented the whole time. So this study found the physical and psychological and social adverse effects would remain in long-term postpartum periods with these women. So it held on for a very long time within this particular group of people. Women reported immense psychological trauma affecting them at home and work and intimate relationships. So it took them approximately 4 months to resume day-to-day activities and 4 to 6 months to resume their intimate relationships, which can obviously affect relationships as a whole. I think this article was the one that said it also took them a very long time to return to work, which resulted in job loss and monetary funds. It was also found that they did not have the support they needed from their insurance or care teams post-operatively to have a long-term plan that would help them get through the postpartum stage. So that affected their mental health, and unfortunately, they did not do so well. Like I said, this is a year-long study, so it had a lot of adequate and good data and good feedback from the patients because they were inpatient at the clinic. So let's see, I think some limits were some mental health issues at baseline. They were unaware if these patients had that to begin with. Okay, so article number 4, it was a cross-sectional analytical study of 50 women. They underwent hysterectomies in Iran. So this was 2017. So they had the consent to participate in this study with a maximum age of 49, and have to be a candidate for a total hysterectomy, which I found pretty good because a lot of the other studies didn't really limit the participants. They just kind of pick and chose. The evaluation for this study was life expectancy determined before and after hysterectomies. The Miller questionnaire is kind of like it's a questionnaire that dictates the hope of individuals after surgeries, mainly hysterectomies, in this incidence, and their will to live, pretty much. So with this study, I didn't really like this study that much, but I kept it in here because it didn't find evidence that mental health was a factor at the end, which I found kind of surprising. It was found that the questionnaires had no significant difference between life expectancy before or after the hysterectomy. But I find that kind of weird because hope is kind of individualized. You know, you can't really dictate that on a questionnaire. It doesn't really make any sense. But I kept it because it was the only one that didn't agree with my topic. So, all right, last article. This was a study of 136 women, ages 30 to 50. And this was out of Pakistan. This was a year-long study between 2015 and 2016. This study explored the similarities between depression, anxiety post-total abdominal hysterectomy. It was noted in the study that most women suffered from a mild to moderate form of anxiety post-procedure, but none with severe anxiety. Depression was noted at mild, moderate, and severe levels and was much more common in these cases than anxiety, which makes sense. Depression was noted, mild, moderate, and severe levels, and was much more common in these cases than anxiety. In the US, among other major surgical procedures, only appendectomy suppresses hysterectomy, like I said before. Before the age 60 in the US and UK, hysterectomy is 1 of 3 in the US and 1 out of 5 women in the United Kingdom. So the women in this study included women who have undergone hysterectomies for other reasons or underlying psych issues. On the strengths on the study, the many limitations ironically gave a wider set of results with differing factors. This study had a lot of limitations for you to sign up for it. I think you had to be of a certain age, you had to sign consent, you have to have had a hysterectomy or not. So, I mean, it had a lot of factors. I kind of like this article, but I think it was a good one. But it didn't really show depression. It showed more anxiety symptoms than depression symptoms. So research was shaky on this topic. Alrighty then. So literature summary. So like I said in the beginning, I didn't really find a lot of journals out of the US. So obviously there's a lot more documentation that needs to take place in the United States. The Western Hemisphere obviously has a lot more in place as far as research on this topic. But that's fine. But it is noted in nursing that we obviously need to do a lot more preparation for these patients in the long-term setting. They need a plan of care that helps them even when they go home, because a lot of people don't talk about their mental health. It doesn't matter. I mean, it's not the priority. They just had a baby. They just lost a baby. It's not the priority situation. So they quietly suffer. So and that's a problem. So, but yeah, do anybody have any questions? I'm melting. I'm sorry. I rewrote my notes about 15 times today. It's terrible.
We'll have some questions for you at the end.
Oh God, please don't. I didn't mean to turn it off.
Yes.
I don't think I turned it off.
Leave it just like that.
I can feel my face.
If it goes out, I think we just escape and it comes back. And then we'll go ahead and close her out. And then we find whichever one is yours.
And I hit this go.
Didn't. There we go. And.
Okay, I'm Tammy and Tammy Hawkins, and this is my PICO presentation. Okay, so my first year of nursing school, my son was about 3 or 4 years old, and when I would stay up late to, try and study for tests or quizzes, he would be up with me too, but he wasn't quietly up. He was like bouncing off the wall, jumping off the bed, or throwing stuff down the stairs. So I was complaining to my sister, like, I cannot study with him being up all night. So she suggested that I give him melatonin. And I asked her, does it really work? And she was like, yeah, they have some specifically for children. She said, and that's what our providers write to patients on our floor when they can't go to sleep. So I picked some up the next day, gave it to him. And I thought it was like a miracle drug. Like, he was asleep, I was able to study, So a couple days later, I went to work, and then one of my coworkers was like, well, how's school going? And I'm like, well, it's going better now since my son can go to sleep and I give him melatonin. And she was like, well, I came across an article that said that if you give kids melatonin, it may be linked to early dementia. So that brings me to my PICO question, is does melatonin administration to pediatric patients with sleep issues increase the risk of early onset dementia? So my population was pediatrics, interventions with melatonin treatment, and my control was early onset dementia. And the outcome I came up with is melatonin treatment does not increase the risk of dementia. And so I have some topics to kind of support that outcome. So first I want to say, what is melatonin? So melatonin is a hormone that's naturally produced in the body that is released by the brain. You have a constant low level circulating throughout your body, but is more released upon nightfall, and it helps regulate your circadian cycle and sleep patterns. Melatonin has been used for various different things, such as treatment of jet lag, anxiety before surgery, and even in children who have sleep disorders. So my first article, it stated about 70% of children do not get enough sleep. So in young children, you can see that they become more irritable, cranky, and they tend to misbehave more in school. And in adolescence, you tend to see an increase of obesity, hypertension, and depression. And it also leads to unsafe driving incidents because they tend to fall asleep behind the wheel. So in this article, the authors did review existing research on the physiological effects of the chronic melatonin administration. They tested the immune system, the cardiovascular health, and metabolism of patients who were receiving melatonin. They also discussed the potential clinical applications of melatonin, such as in the treatment of sleep disorders and certain types of cancers. The research method used in this article is a literature review, which the authors critically evaluate and synthesize the findings of previous studies on the topic. And they did find that it did improve sleep quality, reduce inflammation, but its long-term effects on human health are still not understood. Okay. So in Article 2, this paper aims to provide an integrative review of the regulatory aspects and evidence of melatonin used for sleep disorders and insomnia. The research method involved was a search of multiple databases to identify relevant studies that explored the efficiency and safety of melatonin for sleep disorders and insomnia. And the study was an integrative review of 32 studies that met the inclusion criteria. The results reviews suggest that melatonin is an effective treatment for sleep disorder and insomnia with minimal adverse effect. And it also pointed out that some melatonin do have a variation in the actual amount of melatonin tablets. Between melatonin tablets and liquid. So they found that while the label may say one milligram or one amount, it may be different from what they actually did a study on it. So they said that you should do your due diligence to do research before buying and make sure the dosage is correct when it's on the label.
Okay, in Article 3, it stated that since 2012, there has been an increase of 530% of children who take melatonin. And in 2016, sales were at about approximately 285 million. But by 2020, sales had increased to 821 million. Most prevalent is through the COVID epidemic. And I feel like kids were at home, they were getting on their parents' nerve, and they just gave them melatonin, make them go to sleep. So net numbers are still steadily increasing, and they said estimated about 4 million kids take melatonin each month. This paper also showed that it was effective treatment for sleep disturbances in children. The research method used in this study was a systematic review, and they analyzed the existing literature on melatonin to treat sleep disorders in children. The authors searched that the studies use predefined criteria, and it includes 19 randomized control trials on 1,327 children. And the main findings of this study show that it did improve sleep latency, and that's the time that it takes to fall asleep, total sleep time, and sleep efficiency, and that's the proportion of time spent asleep while in bed. Okay. So Article 4, this article aims to investigate the effectiveness of melatonin in improving sleep quality in children with neurodevelopmental disorders. Those disorders can include kids with autism, ADHD, and Down syndrome. The research method used in this studies was randomized, double-blind, placebo-controlled trial. The study includes 63 children between the ages of 4 and 15 diagnosed with neurodevelopmental disorders and sleep disorders. And the study found that children who received melatonin did have a significant improvement of sleep latency, total sleep time, sleep efficiency compared to those who took the placebo. Okay. So Article 5, this article aims to review the current evidence of pharmacological treatments for kids with sleep disorders. The intervention could be effective. They did find that the intervention could be effective in treating sleep disorders in children, but there was no review available to determine the safety and efficiency. So this was done between 2000 and 2019, and they did compare medicines such as melatonin, antihistamines, benzodiazepines, and antidepressants. The findings did show that melatonin was the most commonly used pharmacological intervention, and it was found to be the most effective with little to no adverse effects. So, in conclusion, melatonin is a safe and effective pharmacological intervention in treating sleep disorders in children, but further research is needed to determine the optimal dose, duration, and treatment, and its long-term effects on kids with neurodevelopmental disorders. So how can this impact nursing? So this would be beneficial to those who are seeking a career in pediatrics, or who will be working in a doctor's office that primary population will be pediatrics. You want to tell the parents or guardian not to give medicine as the first choice to help your kids sleep. So what you want to do is put your kid on a sleep regimen, a healthy sleep regimen first before you introduce melatonin. And what you can do is set a time for your child to get up and go to bed same time every day. This will help regulate their circadian cycle, and it helps them fall asleep faster. Another thing you do is turn off all electronics an hour before going to bed. This includes laptops, cell phone, and TV. So electronics have a blue light that emulates that it decreases the amount of melatonin that your body releases, and it also stimulates your wake cycle. Another thing you can do is you can give your child a bath before bed. This helps soothe and relaxes them. You can sing a soothing song. For my child, he liked Twinkle, Twinkle, Little Star. And, or you can read us a short story. 5, you can eliminate daytime naps or just keep them at a bare minimum, like, they say only 30 minutes. After that, you need to wake them up and then limit caffeine, especially in the evening time. And the most important thing is you can get them outside to exercise, help them expend some of their energy. So by the time it's time to go to bed and you do all these other regimens, that it will help them fall asleep faster. And it takes 2 weeks to develop a habit. So within 2 weeks, you can get this regimen going. And if you have a child with neurodevelopmental disorders, like my son, he has autism, so melatonin does work for him. You can use this in conjunction with the sleep regimen, but you're supposed to only use melatonin 2 weeks at a time. So once you take it away and you have that sleep regimen in place, then you don't need the melatonin anymore. This should be efficient enough. And that is it. What is your, oh, that, okay.
All of the presenters come up to the front and we'll get ready for our questions. Oh, okay. It'll be you. We only have 500 questions.
But did you saw me know already, that should answer your question.
Y'all want chairs or y'all want stand or y'all want that?
Oh, it's gonna be that
I'll
long.
sit down.
No, I'm just asking.
I'm ready.
Okay, questions?
I have a question.
Oh, yeah.
About the ketamine. I wonder if when you were doing your research, what barriers did you find to like why it's not used more often? Because I have heard really good things about ketamine use for depression and anxiety, but it's still not used very often. So I was wondering what barriers did you find, if any, and like, is there some severe adverse reactions that is the reason why ketamine is used last?
Probably due to just not having it's just still not a lot of good long-term research on it. Everything that I pulled is more recent. I couldn't find any articles for 10 plus years ago, 15, 20, that didn't even exist. Plus, ketamine, there's a little bit of a stigma with it too, that it is a drug, drug that people do abuse too.
Right.
It does have delirium, psychoactive abilities. People steal it, use it, causes hallucinations. So there's a little bit of stigma with that too. And I didn't find any research pertaining to younger population. It was all swatted on adult populations. There was nothing with children. That would be, I'd like to see some research done in that. There's nothing with elderly, how that pertains to it. And it's just, it didn't really seem like it pointed to, it's like a good option for like a first line use, like any, like it still seemed like, it wanted to point towards traditional antidepressants and stuff like that, and other options before they would try that. But it's probably just a lack of research that's been done on it. I have a friend she's actually a therapist in town too, and what she's saying is more of a push towards research, and what she's interested in is things they're doing with MDMA, also with depression and stuff like that. And she hasn't been seeing as much with ketamine. So it's maybe just a lack of long-term research on it, but everything that I pulled up seemed quite promising from what I saw on my end. But
Right.
There are questions from the audience?
I do have one more. Sorry. About the melatonin. I was wondering, did you find any specific research that linked the melatonin to early dementia in people? Because when you were presenting, I was thinking, melatonin in kids kind of just became a thing like the last 10, 20 years. So I wonder if there's really not even, those kids aren't even old enough.
So that's what,
the symptoms
yes.
to know if it actually is linked to it or not.
Well, they haven't done enough studies on it, so it's still ongoing, but as of right now, researchers do not know the long-term effects of it.
Right.
So
I can tell you, I'm more forgetful when I take melatonin.
you are.
I used to take a lot of it, and weaned myself this semester because I found one, not only did I find myself getting angry for no reason, which was very strange.
Mhm.
I was so forgetful. I could not like retain memory almost. It was very weird, but I was taking a lot of melatonin.
But,
Weird.
some research did say that, when you take too much, you get, irritable, cranky, and a little daytime sleepiness. But I say after a couple of hours, that subside and no more adverse effects of it. Just have to wear it off. Mhm.
Anything else?
Going once, going twice.
I'm ready to go home.
I like being right.
It's so good. Yes, we did. Yeah. Okay. Yeah, you did Did everyone get your certificate and t-shirt? Yeah. Okay.